Thank you, Jordan, for the excellent overview on the screening. So now we have a panel discussion about the two presentations from Einer and Jordan. So if there is any question from the audience, let's see. Otherwise, yes, please.
So Jordan, I'm just curious. So in terms of the core antigen testing on dry blood spots, what are your thoughts? Is 92% sensitivity, is that good enough? And I guess, again, it gets to your point about the setting. So maybe you could just elaborate on where you think that a test with a sensitivity like that might be useful.
It's for sure a good point. I think there are probably ways to get that sensitivity up even a little more. So as I mentioned, we used 2 spots. You could use more. I mean, the issue is blood volume. We didn't try going up to 3 spots, but maybe you could do that. And you're probably right that for the only rationale for using it would be a cost-saving measure. So you'd have to think in a setting where probably a low prevalence setting where you wanted to screen a lot of people, and potentially if there was going to be serial screening, it would probably be reasonable. But I think your point's well taken that sensitivity is better than doing a single spot, but it may not be adequate to endorse it broadly.
Hi, thank you for that presentation. It was very interesting. Between the point you were trying to make about Egypt's prevalence and towards Canada's, I was a little confused. Like for Egypt, for example, they had those anti-schistosomal campaigns where they were doing those vaccines with reusable needles between the 50s and 80s, which is why they have a lot of their lower population are highly infected. Like that wouldn't necessarily apply to Canada, where you had those reusable needles and a large percentage of the population was exposed, and I was unclear about the point you were trying to make there.
Okay. Sorry. I clearly didn't make that well enough. So the point was, I was saying that the epidemiology really is, when it's different, your screening strategy has to be different. So you're absolutely right that in Egypt, it's completely a different epidemiology, and you're right that because of this, the burden in the older population, if they were to only do birth cohort screening, if they only did baby boomer screening, like they're doing in the US, they would miss a chunk of people with hepatitis C. So whereas if we only did baby boomer screening, we would still miss people, but we would miss a much smaller proportion. So that was the rationale.
Yeah, and in Egypt, obviously, it's not only the old population, but also they have one of the highest incidences of acute hepatitis C, even in young ones. And therefore, for them, they are screening all adults, but probably they should also screen all adolescents. Would be still effective there.
Right. Thank you.
Angela?
Thanks both for your talks. Dr. Wedemeyer, I had a question. Thanks again for good coverage of like a good laundry list of immunology things. It complemented well with what you did yesterday, and I was happy to see the fibrosis element. So
I just edited for you.
Yeah, especially for me. Thanks. So, dare we speculate then? Where is this systemic? Driving factor coming from? Is it just that that there's a lot of cytokines in the serum? Is there something maybe a little more direct than that, or that the cells are just bathing in this cytokine storm, or lack thereof, pro-inflammatory, anti-inflammatory, or is the stinky liver really concept even worth looking at, in your opinion? What do you think?
No, and I think this was the discussion we also had this morning, whether it's what is HCV, what is liver disease, so in the non-HCV, and I showed you this, the one from our JRD paper where we compared HCV versus fatty liver disease. So there is inflammation, and NASH itself causes alterations in the milieu, and this is likely inflammation of liver immune cells. They are leaking, and then your stinky room is floating over. But there, with HCV, you have additional specific items which may affect other things. It may be T cell cross-reactivity to other pathogens on a single epitope level. It may be these effects of the virus via CD81 binding to other immune cells, which may stimulate. So I think in the end, it's both, and there the effect may be different for cell type or cell type. In gamma delta cells, we still don't know the exact antigen driving the expansion. There may be antigen specific things or just cell deaths. So again, it depends on the cell type. And the problem then, what does it all mean for the individual patient? And we have the same thing as with lymphoma and HCV. And we discussed it yesterday. So yes, it's quite clear. We all know there is an increased risk to develop lymphoma. It's depending on the cohort, 1.5, 2 point. But if overall your risk to develop a lymphoma is, I don't know what the numbers are, is 50 out of 100,000, even then it's 100. It doesn't mean anything for the patient. And therefore, I think that the challenge in future is to bring all these different effects on different immune cells, inflammation, virus, liver. I think we have to think beyond. We have to use tools to understand, to bring it back to the single patient, and to really, maybe we can use it for risk stratification. We are not there yet. I think we first have to do our homework, understand each cell type, and then somehow bring it together.
Good. Thank you.
And therefore, HCV is such a good tool on this almost impossible pathway to understand all the networks. Usually, for students, I have usually a slide bring with all the different immune cells, dendritic cells, CD4, CD8, Treg, NK cells, MAIT, gamma delta T cell, and everything interacts with everything. Then I have usually my figure where arrows are going back and forth, and there's a chaos. And to really get a clearer picture, we need tools where we can disrupt one of the pathways. And HCV is fantastic. And if we have a chance to understand something which we then may use for other diseases, HCV is the thing we have to work on. And therefore, all the things we discussed, fine needle, liver, lymph nodes, etc., this is the way to go. So HCV research continues.
Thanks, Heiner. I thought one of the most interesting things you talked about was the HCC-specific T cells. Are they present in patients that are non-cirrhotic? And do they go up as the fibrosis progresses to cirrhosis? Do you have like a indication?
So again, there were too many. So also from a didactic perspective, I had far too many things in that that talk. So when you remember the one slide where I had these responses in the cirrhotic patients, there were one healthy group and one group non-cirrhotics, and there it was very low. Mm-hmm. There are always, and then it's again with these assays, where's your cutoff when you do the proliferation? Is it stimulation of 2 or 3? So there is, let's say, a noise ongoing, and it's an endogenous antigen, so it's no surprise. Mm-hmm. And probably, obviously, in the cirrhotic patients, you have a lot of cell turnover, you have a lot of regeneration, and that during this process, some of these antigens are presented and are inducing some kind of immunity. It's quite clear, but it's much lower in non-cirrhotic patients.
And then as you have the fibrosis progressing, do you see?
We did not really correlate this like in the other paper with FibroScan values. We should do this, yes.
Can I ask you a question about that? Did you look at patients with HCC?
Yeah. So obviously this is what the reviewers are asking back and forth, and whether this is whether, let's say, this response declines in the guys who get HCC. The problem is obviously when you get HCC, you have much more of these antigens presented, and then obviously this is stimulating. So they would need a very close profiling over time. Probably first see a decline during DAA, and then again an increase, and then obviously. Then the number, you would need many more patients, and the number of patients developing HCC in the long term is quite low, even though they all occur, and this is a challenge.
Yeah, I guess I was wondering when you were talking about the fact that what does it mean? Do all these cirrhotic patients have a little tiny tumor, which is probably not true. So is understanding the specificity of these tumor-specific cells for tumor as opposed to being something about cell proliferation or something else, and that's
let's say the antigens in the HCC immunology field, they have been studied very well, and also the one thing is the pools of the peptides. The other thing is really tetramers or multimers targeting a single epitope, and there have been very nice studies also in patients receiving local ablative therapies or TACE or so, where these responses were actually could be correlated with long-term outcome and with this tumor progression. Yes, there is some, as I mentioned before, some, let's say, unspecific background thing, but it's really, in the tumor field, a very strong antigen.
Roger Leblanc, Clinic Opus. It'd be interesting to have your overview on inflammation and screening for the intersection of HIV-positive men on treatment, PrEP cohort of men who may or may not be on PrEP, who are engaging in high-risk sexual behavior, inflammatory lifestyles, chronic drug consumption, sleep deprivation, multiple recurrent syphilitic, proctocolytic episodes, how often should we be screening them for Hep C?
Okay, well, I think there's two questions. There could be two questions there. One is how often should you be screening them, and then I think there's a question potentially to Heiner about how the many different things that you raise in terms of the more global and systemic effects may affect the immunology and also the outcome of hepatitis C. In terms of screening, I mean, the general recommendations are to screen relatively frequently in people who are engaged in risk activities of any kind. And, you could, if you want to, it depends on your purpose. If your purpose is to find the infection, to find all of the infection episodes, you probably need to screen about every 3 months. If your purpose is to find all infections that turn into a chronic infection that might have consequence, then probably screening annually is enough. And that's actually what most of the guidelines recommend.
Because what we're seeing is such a high incidence of inflammatory disease, ALT screening is useless because it's often driven by alcohol.
Yeah.
But that we're having people infected but are intersecting in a application network where that single Hep C that just got introduced into the field has already slept with 15 or 20 other people.
Yeah.
And we're beginning to see patients who are HIV negative or becoming HCV positive.
Yeah.
But it's often after multiple episodes of LGV proctitis, syphilitic proctitis, repetitive trauma, perforations of the rectum. So there may be another group of population we don't think at risk of sexually transmitting Hep C. And it's just, that fits in with inflammation, and I just thought I'd toss that out there.
It's an important point, and I think that the screening strategy, you need to screen frequently, and if you're worried about outbreaks, you need to actually screen very frequently, because if you have individuals that are transmitting at a high rate, you want to get those people ideally treated so you can have the prevention
We're doing
effect
almost
of
every visit,
treatment.
which nobody's told us how much it costs yet.
This would be my question then to you, Beck. And this is what we also discussed in Berlin during the EASL meeting last week. The question is really, you have the population-based screening, but if you have 100 patients, the transmitters maybe only 3, 4, 5, and they are transmitting to many others. So it's really, I think that the key challenge is really to identify those high-risk behavioring persons who are probably less likely to attend screening protocols, right?
Well, I mean, that's true, but I think that's why you need to change where you're screening. So if your goal, I mean, and this has been nicely shown in the U.S. that when they introduced birth cohort screening, they were very good about screening in suburban clinics in the Northeast and getting all the baby boomers who had a very low prevalence of Hep C screened, but what they weren't good at identifying was people in some of the less well-off communities that actually had a higher prevalence, and that's why they moved screening to emergency rooms and to inpatient settings and to drug and alcohol treatment centers. So I think if you're right that people who have a high prevalence of hepatitis C may not engage in the screening protocols, but then you need to change your screening protocol.
Just pragmatically, Jordan, obviously there was a document that was released to us last April from the Task Force on Preventative Healthcare, just advocating a risk-based approach as opposed to a population-based approach. And I think many of us in the room have been working to try to advocate against that document. So I'm just wondering if you could speak pragmatically around how damaging was that document, in terms of actually causing major difficulties in improving the left side of the cascade. Mm-hmm. And what can we do as a group and at a country level to try to counteract that document and try to advocate for a more evidence-based population screening approach?
Thanks, Alex, for bringing that up. I purposely didn't mention the task force recommendation, and I think it is a challenge for all of us in the community that feel that probably was not I could go through that document and had my whole talk just talking about why it was not a well prepared recommendation. I think there were some major challenges with it on what evidence wasn't included, how it was misinterpreted. But the one thing I will say about that recommendation, they did acknowledge that the quality of although they said it was a strong recommendation, they did acknowledge that the quality of evidence supporting it was weak. And one thing they did call for was better data gathering to fill the data gaps and really put the evidence base in place that will justify a change in that recommendation. And so we had this one small study of doing a seroprevalence study where we're just doing surveys, not modeling, just actually testing people. I think those type of studies are necessary. Sometimes they're not sort of sexy. No one just wants to go out and test a bunch of people and find out who's infected. It's not all that gratifying as a study, but it's important. And I think there was a meeting just on Wednesday, which Mel Krajan organized, trying to get people together and look at what data do we have and how can these data try to be improved upon to help inform what should be a better recommendation. And then there's the other side of it, which is when we as a community feel that recommendation wasn't the correct recommendation. And I think many people did respond with letters to the editor, the CMAJ, where it was published. People have talked about it widely. And I think we should continue to do that. But I also do think that we should continue to collect the evidence to make sure that we actually are advocating for the right thing. Because one big thing we still don't know about is the diagnosis rate. And if our diagnosis rate is very high, then it may be better to put our resources into linking people to care, finding people who have been diagnosed and never linked to care, than to screening. And to be honest, I don't think we know that entirely well yet.
So I have actually a question for Dr. Wedemeyer. I was very fascinated by the fact that you put together in your presentation both the decay in the liver stiffness post-SVR and the cellular fingerprint, let's say. So I was wondering, do you think that a combination of these things could help us detecting, the golden mine, which is those patients who are actually post-SVR at less risk of developing HCC, and then where we can spare in some way the screening for HCC? Because now, as you know better than me, the guidelines recommend to screen all of them, basically.
Well, I think this is a very important point. So what I showed you, the correlation between fibrosis and some of these inflammatory markers was purely baseline. I did not show you that the post-treatment correlation was not good as the pre-treatment one. So, but you're absolutely right. One part of research should address this issue: which patients are at risk, and even if in a cirrhotic patient post-SVR, you have, let's say, on average 1 maybe to 1.5% annual risk to develop HCC, we need good biomarkers, and the performance of the biomarkers is unknown, and we simply need to work on that one. So an unanswered question.
Any other question for Dr. Fellow, Dr. Wedemeyer? Okay, so yeah, very last.
Your paper, Dr. Wedemeyer, last year of persistent neuropsychiatric problems post SVR was my favorite paper of the year, and
I'm only co-author. I'm not the last author, so we provided the patients to our neurologists. Yeah,
I'm just wondering about since we have an overdose epidemic, that my little mind works on these percentages of people in the drug-using population who may have spontaneously cured. And as your paper noted, they do the worst for neurocognitive performance. Are we missing a point in addressing the overdose epidemic by not talking about those problems?
Yeah, so you were referring to, obviously, the paper that neurocognitive dysfunctions, depression, fatigue, to what extent do they disappear after HCV clearance? This is the one point.
Yes.
The paper you were referring to were either spontaneous clearers or some patients who cured after interferon-based therapy. And in the old times, obviously, with depression, so how much maybe had interferon contributed also to some of these dysfunctions? I think we need more studies also regarding this point on the interferon-free cure, I think, which is very important. We discussed also with the fellows yesterday to what extent, let's say, risk behavior is really going to change by, and maybe also symptoms, depression by HCV cure. Again, an open field. More research is really needed to answer this question. But also the fact that, let's say, the systemic inflammation does not change really, and that this, as we all know, if you have inflammation, you have symptoms like depression. We have another paper where we really could correlate neurocognitive dysfunction with immune parameters, so the soluble ones and the other ones. And if this is not changing, that then some of these symptoms are persisting is somehow quite logical. But again, more work is needed on that.
Thank you.
Thank you for the speakers. Excellent. For the excellent speakers.